It is a great pleasure and honor to be in front of you all today to present my few years experience on COVID-19 pandemic and pandemic control in Sri Lankan setting. So today my talk is mainly focused on impact of COVID-19 pandemic on communicable disease transmission patterns in Sri Lanka, and what lessons that we learned during the pandemic era, and how these pandemic influence the many of the disease transmission systems in the country, and also what kind of interventions that we have to positively and proactively take in future that kind of event. So those are the general type of things that we are going to discuss today. So the outline of my talk is on the first. We are going to just describe on what non-pharmaceutical interventions are and how we can measure them, and how to measure the community adaptation to the public policies and pharmaceutical and non-pharmaceutical interventions, and what kind of impacts of non-pharmaceutical interventions in terms of human mobility restrictions, specifically on vector-borne diseases, taking example as dengue. And fourthly, we are trying to just elaborate and just have a discussion on the impact of other communicable diseases on these health policies. And then finally, we will talk about the lesson learned on these non-pharmaceutical interventions and their effect on the disease transmission systems. So first, we will just recapitulate our knowledge, because these things are well known, the COVID-19 pandemic and responses. So these are the kind of non-pharmaceutical interventions in which the countries adapted in different magnitudes and in different time scales. Social distancing, face mask, wearing face mask, hand washing, restricted access to public places, school closure, travel restrictions, working from home policies, quarantine curfews, or lockdown interventions, and other context-specific interventions. So those are some of the non-pharmaceutical interventions that I elaborated for an instance. And then it is important to see how the countries has adapted and how the countries has implemented these policies, which as an index, as a quantifiable measure. Because without quantifying these intervention policies, it is very difficult to estimate the effect size of outbreak or epidemic on its own for the COVID or for any other infectious disease system. So it is important to quantify. So let's see how the people have quantified these government responses. So thanks to the Oxford University colleagues, so they have developed Oxford COVID-19 government response tracker, which is a very useful tool, which is also available online, and it is freely available. It's a measure of government responses. It is a quantifiable index values of government responses, which they put tremendous effort by searching a lot of databases in every country. So they have these responses quantified for 180 countries in the world. So then it is an enormous database, and they continue it up to now also. So you can just go to that website and download the responses of any of the countries, or even in your countries you can download. So it is very well known, and up to now the people are talking about these things, and then it is not novel knowledge for us. So just for the completeness, I will explain how they have quantified the government responses. And there are four basic indices actually they have identified: government response index, stringency index, containment, closure and health policy index, economic support policies index, because all these things come in par with the conference major theme. So that is why I decided to, extract some of the information from this valuable resource. And then this is in the table onto your left-hand side, table 1. So these are the Oxford government response tracker indicators. So then for the containment and closure index, there are several indicators starting from C1 to C8, school closing, workplace closing, cancel public events, restriction on gathering size, close public transport, stay-at-home requirements, restrictions on the internal movements, and restriction on the international travel. So likewise, they have categorized different interventions. And as you can see in the table 2 on to your right side, so they have assigned values to each of the indicators. And then finally, they obtain the cumulative value. And based on these selections, so GRI has a selection of very many variables, and CHI has selection of some other variables, and stringency index also selections of some other variables. So just a matter of selecting the variables and assigning values, so then you will get different indices. It's a time series. It's basically a daily time series of different indices starting from 2020. January, and then it continues up to now even. So as you can see that they have captured all the dimensions, economic responses, and also the health system adaptations and health system responses, and also some miscellaneous indices and categorized as other responses. So it's a chunk of information that researchers can use to quantify. It's specifically towards the quantitative research analytical studies, and it is a very good chunk of data that we can see. And also now it is also very important to see how these impacted on the human mobility or the behavioral components or the behavioral adaptations to this non-pharmaceutical or public health or any other government policies. So how we are going to get an idea whether the community is adapting. So it is very difficult at the face of the pandemic, unless the Google has very generously provided the Google COVID-19 community mobility report. So that report generated by capturing the mobility of the mass movements of the people by capturing the information from their mobile phones. So then that is also freely available. You can search it as COVID-19 community mobility report. So it's available in the country or state level at the moment, and it is continuing. And they also have several indicators. So I will show you how these indices, once we put on a time series graph, and with respect to here in this time series graph, you can see the x-axis is the time in days, starting from January 2021 and ending from June 2021. So just for a purpose of demonstration. So then the y-axis of your left side is demonstrating the COVID-19 cases, the number of cases that were reported daily from the national surveillance systems. And then it shows that there is some downward trend towards April, and then again, then the number of cases are going up. So these are historical data, not the present time. And also, this orange or amber line would be the government response index. So it's a time series, fluctuate in certain areas, and it going down in some areas, and gradually it is going up. That is because of as a response to this increasing number of cases. So then that is how the Sri Lankan government has relaxed their stringency at some point, and then after that they have increased to the maximum effect, where the lockdown intervention has started from 17th May 2021. So this is a kind of a representation of the government policies in response to epidemic. So that information is useful because we can get a lot of inferences by looking at these things. So then this is again the same period, and also now we captured the behavioral component as well. So these red, blue, green, and maroon lines represent the residential mobility, groceries, and recreational workplaces. So those are the Google mobility values. So Google mobility report provides you this type of time series information with different endpoint. So residential mobility means the proportion of the people who are residing at their premises at a given time when compared to the baseline level of residential mobility. So what happened? So it's gradually decreased residential mobility, and then there is something happened in 14th of April and 1st of April because government has relaxed their stringency, and then as a response the people who visit to groceries and all has increased. And 14th of April, as most of us know, it's a Sinhala and Hindi New Year festival day. So it's a public holiday for the entire country. So being a public holiday, and then the people mostly going to stay at home, and they are not going to work as there is a downward trend in the workplace mobility. So it is mostly the pattern, divergence pattern has changed on the holiday. So it captured by this Google mobility. And also what happens now, as we saw in the previous slide, and then after some times after this relaxation, the number of cases are going up. And then as a response, again, government has imposed the lockdown intervention on 17th May mainly for the purpose of controlling the increasing number of COVID-19 cases, and then see how the pattern changes now. So there is only two ends. One end is the residential, which is going up. That means that more people are staying at home and less people are going to work, and less number of people are going to the groceries and pharmacies or recreational or any other places outside their residence. So it seems now the people are they have adapted the expected behavior imposed by these policies. So this is having these features and having this phenomenon in mind, then we'll move on how this the vector-borne diseases dynamics also change. So here I'm little bit elaborative on this dengue disease because it is important to understand the transmission dynamics of any of the communicable diseases for us to understand the influence of many other factors and determinants, and also the influence of the contributory factors which govern these transmission dynamics. So dengue, we all know it's a viral infection caused by 4 closely related viruses, DN1 to 4, and it is transmitted by mosquitoes. Aedes mosquitoes, there are 2 basic types, aegypti and Aedes albopictus. And the disease has a very broad spectrum of clinical manifestations, starting from ranging from non-specific viral syndrome to fatal hemorrhagic diseases. And its nature is it's rapidly spreading, and it's spreading in tropical and subtropical areas. Now, over the 50% of the global population to be at risk of dengue. And it is a significant public health challenge and economic burden in affected countries, and Sri Lanka is not an exception because of being a tropical country. And there is no antiviral drug or population-wide safe applicable vaccine developed at the moment. Therefore, the main methods of prevention is vector control interventions. So then this is the entire system. I hope you can see the screen. So this is the entire system. We know that mosquito has 2 stages in their life cycle. Terrestrial stage, which we can see as an adult mosquito, and the aquatic stage, which we can see as larvae, pupae, or eggs. And once the adult mosquito emerge, and they stay for about 3 days in the environment and then go and bite a human, supposing that human is having virus and having the infection, and he's in the infectious or transmissible stage of the virus, and then the virus go inside the mosquito, and the mosquito incubate the virus, and then he go and bite another naive host who is not having any of the diseases, any of the elements of the dengue, and then the person develops the dengue after a period of incubation period of some days around 4 to 10. And then mosquito can come and bite the person, and then the person would be in the viremic stage, and then the virus can get into the mosquito. So then that will complete the system of viral transmission with in between human and the vector. And also there are certain other factors like temperature, rainfall, El Nino southern oscillations, which are environmental factors which contribute to contribute to these transmission dynamics, because it's changed the behavior and longevity, and also that vectorial capacity, or the capacity of the vector to transmit the disease and all in the environment. And it drives the dengue epidemics, because the rainfall needed to fill the most containers with water for the adult mosquito to come and lay eggs. And also importantly, what will happen for the mobile population, human mobility, because now there's one place where the system is active and the transmission is happening. And if supposing what happened to a group of people, or the family moves to that place, so then they were already vulnerable, and they again becoming themselves as a higher risk of interacting the disease because of their mobility patterns. And that we have to keep in mind. That is also important thing, important contributor, other than the globalization, urbanization, and some elements of climate change. The human mobility plays a significant role in spreading the disease, because human can move for a long distance compared to mosquito, which is a very restricted flying distance with around 200 meters. So compared to mosquitoes, the human can fly any area in the world, because of this type of now is a more globalized world, and with the air traveling and all these things in many places in the world. So the control, mainly we focus on the vector control in source reduction, where we go and remove the bleeding places, and also we prevent as much as possible the interaction between the adult vector and human. And also what happened during the COVID-19 epidemic, so that is very important, by restricting the mobility of the people, what happened to these transmission patterns, transmission systems. So this is what we observe. So I mean, these are two maps of Sri Lanka, showing the 5-year average on your left side, and also the map of second quarter 2020, where just after the COVID-19 lockdown for first instance. And then what we saw, so here this 5-year average, so all most of the districts are more than 100 per 100,000 population, the cases, the incidents. And see, then after the COVID-19 lockdown, after some period of time, then the number of cases, incidents went down, and most of the districts was below the 0 to 40 level, belong to the 0 to 40 level, and only few districts that shows that 40 to 60 or 60 to 80 level of the activity, disease activity. So why is that? Why that change happened? So it's very important. It's very important epidemiological scenario that we have to investigate, and we have to get an idea why this has happened. Why this, very notorious disease, which was spreading and which was harming the people, and why it was reduced after the restricting the COVID-19. With the COVID-19 policies. So is it a good thing or it's a bad thing? So it's just an observation, or there's a statistical significance of that, or it is just something happened due to chance. So those are the questions that came into the mind of the researchers who conducted so this kind of analysis. So this is the pictorial and again the time series of everything. So then this is year 2020, January to December, and I selected here the Western province, and also this line, this continuous line represents the 5-year average dengue cases from 2015 to 2019. And here the average dengue cases in the red line is 2020. So it is across all the districts in the province. So it shows it's going down, and also adults number of cases also going down, and then the infants or the child cases also going down. And this segment is the routine outbreak control interventions. You can see it in the pink color. And also the 20th March 2020 is the day that the national government imposed the extensive mobility restriction, or amounting up to the lockdown policies. And it lasted until 11th of May 2020. So it shows again the community mobility report shows that the residential mobility going up towards just after this intervention, and the workplace mobility going down just after the intervention, and it remained for a certain period of time. And also we know that in the dengue is a seasonal disease, and we expect the seasonal increase in the dengue, and we observed the seasonal increase in the dengue for the 5-year average period from 2015 to 19, somewhere around June. So in July, we haven't seen such an elevation of the number of dengue cases. So that was the first observation, and then we conducted the research, and then we were able to publish this study in PLOS NTD, and it was the impact of COVID-19 lockdown on dengue transmission in Sri Lanka, a natural experiment for understanding the influence of human mobility. So that is what we actually published, and after which the methods that we use to, just for the purpose of enlightening you all, those who are having some interest. So the main method that we use is the interrupted time series analysis, which is a research design, it's analytical design, mainly focus the analysis of health policies, which particularly has a very abrupt onset in implementation, and then it's a quasi-experimental analytical design as well. And it has the ability to regress many other time-varying confounders like climate parameters or long-term trends and all, and disease surveillance patterns and changes in the public health and any other thing that are there as a data. So the models can make a regression analysis and give you the exact effect of more or close to the exact effect of these interventions and their impact on the outcome. And then what we did was we first stage, and in the first stage we evaluated the impact by district, and then we pooled this impact, district level impact, to climate zones, because climate zones play a very significant role, and then they are different in their transmission patterns. So then wet and dry zones we selected, and also in the Western province we selected the age groups to see the differential impact on the climate zones and the differential impact of the age groups of the dengue patients in the country. And also we were able to capture certain things that are there in hospital care seeking behaviors of the patients to eliminate their effect, because now we know that some people might think that, okay, now because of the COVID, the people may not have gone to the hospital. That may be the reason that dengue reduced. So to counteract that argument, so we collected a series of data in terms of the disease severity, dengue hemorrhagic fever to dengue fever ratios, and all historically, and we were able to show that there is no such deviation in the hospitalization of the people having dengue, because dengue is very widely spoken, and health education programs were continued throughout to promote the hospitalization behavior of the people who are having symptoms of dengue in the midst of the COVID-19 pandemic. So those are the other related policies that we have to consider once we analyze one policy. Right. Now this is just to give you an idea of what happened during that epidemic, and also its model estimates of their effect size. And then effect size of the national level is 0.12, the relative risk estimate. So relative risk was reduced. That means that's an 88% reduction national-wide of dengue cases, so compared to the 5-year average. And zonal differences are there. The dry zone mainly has the major, highest impact out of these two zones, having 0.09%. And wet zone having a relative risk of 0.17, that is close to 83% reduction. And the Western province, again, 84% reduction. And children were affected mainly. They were the group of people who had the huge impact, because probably because of the extended period of school closure. And they showed that there is a 92% reduction of the cases, incidence among children. And adults, there is again around 86% reduction of the incidence as depicted by 0.12 of relative risk. And these two time series plots also show that wet zone and dry zone. And then this counterfactual estimate is the estimated number of dengue cases without this intervention. So if we assume that there is no intervention had happened, and then that is the amount of cases that we could have observed during the same period. So that is the model estimate. So that is the basis of calculation of this relative risk as well. So I'm not going to go into much details of this, but anyway, the things that come in coming slides are much more interesting and important, therefore that we can just move on. And then we'll see, okay, now dengue, we observe some reduction. So what happened to the other diseases? Because the diseases are complex systems, because they blend each other, and policies also go, have various impact on the diseases, different diseases. Okay, now this is the level of understanding of the mobility, impact of mobility restriction on dengue in global level. So soon after our publication, for sometimes later, the Lancet Infectious Disease published this very interesting article on measuring the effects of COVID-19 related disruption on dengue transmission in Southeast Asia and Latin America, a statistical modeling study. So then they identified, okay, now with the stringency levels at different time periods, and then as shown on this graph D of your left side bottom, and then this black line is the stringency index level, and concomitantly there is a net change in the dengue incidence given in your right side chart C with different countries. So almost all the countries that are there listed has similar reduction of dengue cases that we observed in Sri Lanka soon after the starting of this epidemic, and then the imposing of this stringency of the stringency level of the intervention. So it shows that, okay, now it's not limited to one country, it is becoming a universal thing, and it is common to many of the countries in the world. So then moving to leptospirosis, what happened to the leptospirosis? So leptospirosis, it seems that there's this again the time series plot showing cases fluctuation from 2015 to 2020 September. So there is a green line showing the observed leptospirosis cases, and we see that there is an outshoot of the cases. So the largest number of cases that were reported in the history was reported in 2020 after the lockdown interventions. So why did that happen? Why that increased compared to reduction in dengue? So again, policies. So people stayed at home, and government promote them to go and work in the paddy fields. And then the paddy field is a known exposure for the Leptospira organism, which is which is mostly seen in the excreta of the rodents. And then the people, their exposure pattern changed, because many people who were not working in the field, paddy field, they went to work in the paddy field. So then that's one of the things that we observed. And then here the log relative risk, which this is a porous plot, and shows that there is a significant increase in the number of leptospirosis during this COVID-19 pandemic. And likewise, what happened to chickenpox? Okay, chickenpox shares some of the similar transmission pattern to COVID, and then hand washing, social distancing. As expected, it should go down, and also we saw that there is some reduction of the risk level of the chickenpox and in relation to this onset of this lockdown interventions. So that is also significant finding, though it is not very statistically significant. We say now it is on the better side, And then going for the tuberculosis, okay, there are again peculiar trends in tuberculosis, but there's nothing much changes usually, but statistically we observe that there's an increase, even though that is not statistically significant. There is some increase in the tuberculosis cases. That is also biologically plausible, because it is again becoming the family context, probably the family context, because the people tend to stay at home for a long period of time. So then there are some concerns in tuberculosis transmission dynamics, but this is what we observe. So here again, what we have to see is we have to go back to see the quality of the data and all, and then there are some mishaps in the data collection and all these things that also give some bizarre picture which we may not be able to understand or explain. And dysentery. So here there's a historical reduction of dysentery. So maybe one factor may be the lack of hospital admissions due to the dysentery. So dysentery may not be a very serious disease as far as people are concerned. And then they can apply home remedies. So one reason may be this lack of surveillance and then lack of hospital admission. But after that period also, then there is a sustainable reduction. So again, it is biologically linked. Okay, people didn't go and eat from outside, as our previous one of the speakers I heard that mentioned, because now it is a matter of staying at home. So then outside food, availability of the outside food limited. And also, that is also again a risk factor, because eating from shops and eating from groceries and everywhere places where we can risk of exposure to the diseases like dysentery. So that is again a biologically explainable phenomena, and this is one of the most important observation that we made. So what happened to this rabies activity? So then this is number of rabies cases that you can see from your left side. It's a time series starting from 2010 to 2020. Okay, now cases came down by 2018, and there's a gradual increase. And then 2020, again, there's some continuation of the increase of number of cases, even though the numbers are small. And it's not the thing that we have to think of, because it is the cause that is very interesting, not the increasing trend that is interesting. Because these cases, I mean, once we analyze, it's not only the human rabies cases, but all the cases that we observe that in animals also. So there are certain patterns. So I have highlighted jackal here, because jackal were not there in the story anywhere from 2010 in the history in our study setting. And jackal came only after the lockdown intervention. Why is that? So the probable reason for this increased number of jackals being dead, and confirmed 5 jackals in this as rabies is maybe some reason. So we'll see. So this is what happened for the distribution of the jackal bites. So it means that there is an interaction, more interaction with the wild animals, like jackals are. They live in very close proximity to the human dwellings and forest and some neighbors, some bushes and all, and then they just come out because of the lack of human mobility and lack of moving vehicles on the road. So that was the explanation given by the veterinary experts. So they came and interact with the dogs and interact with the human, interact with the livestock. And these MOH areas are the medical officer of health divisions in one of the districts in our country. So then I put this slide as an example. So now humans, or total 11 humans were bitten by the jackals, and 30 dogs were bitten by the jackals, 5 cattle were bitten by the jackals, and total of 46 bites. So which were we haven't seen that in the history. So it is also again came up with this lockdown intervention because of the aforementioned reason. So it is also a new finding. It is also a food for thought. Okay, now why this human mobility is also play a significant role in disease transmission. Not only the human mobility, animal mobility also plays an important role. And the lockdown interventions or any other pharmaceutical intervention which has the same potential can influence the animal movements also, and then change in the entire exposure patterns and change in the disease dynamics towards some other direction, which can cause some re-emerging diseases and emerging public health problems we never thought of. So then a lot of intervention needed to curb this jackal-related potential threat of rabies infection in the community as well. So then those were things that we learned. So finally, so I'm going to the end of this presentation. So I have spent around 33 minutes now. So anyway, we can keep some time for the discussion as well. And these are the lessons learned. Human mobility is important as it determines the exposure patterns to the pathogens, vectors, animals, and more broadly to the environment. Population-wide interventions targeted towards controlling one disease can have unexpected influence of any other disease. So as public health experts, we have to bear these things in our mind. One should consider all the policies, all the non-pharmaceutical, pharmaceutical, health and economic, agricultural and other policies as a whole, as they are linked to each other. And as they are the holistic impact of the policies, all the policies is the matter that we have to take very serious account. And we can't think, health policies separately and make some plans, because the determinants may not be basically on the health policies, but the determinants might have gone up to many other policies like agricultural policies and all. And restricting human mobility can change the pattern of the animal mobility as well. So rabies control interventions should be strengthened in vulnerable settings. So we have to identify what are the vulnerable settings, or what kind of wild animals. So it is One Health now. It's a One Health concept now. It is not the entire human public health. It's a One Health, public health of all the animals and all the human beings and all the beings, all the living beings in the universe. So it's come to that stage. So that is one of the important lessons that we learned during this COVID pandemic. So it is more we have to collaborate with other sectors, like veterinary surgeons and animal husbandries and some livestock management departments. So it's a kind of matter of now it's think twice and collaborate more and more with a lot of people that are there looking after different element of the environment, and redefining these mosquito control targets, because now we presume that, okay, now people were staying at home and then their vulnerability would increase. Well, that didn't happen, because the vulnerable areas in schools, workplaces, industrial zones, hospitals, that is the places people didn't go during that epidemic. And because of the mobility restrictions, so in other words, so these are the places where people avoided. So avoiding these such kind of places that reduce the transmission. So then it is once we restart mobilizing, and then the people will again be at risk. Yeah. Okay, now it came to the conclusion. Then it's finally the cross-cutting approach. And with this slide, I can conclude my presentation. And yeah, I'd like to thank all the organizing committee and for the Dengue Tools project, whichever the things that encourage us to do this kind of activities with this research Council, Department of Epidemiology and Global Health in University Sweden, and Ministry of Health Sri Lanka, including the provincial and regional directors, and again ICPHO organizing committee and the TIIKM. Okay, thank you very much.